This is going to be a review of pain medication. So when you're thinking of pain medication, what are some things you want to be aware of? So first of all, you want to be aware if a patient says they have pain, you want to properly assess what that means. What is the pain? What's the pain level? What's the scale? Where is it? What's the intensity? Is it acute and chronic? So as soon as they say they have pain does not mean it's a thorough enough assessment to be able to intervene. So remember when you're going through questions, you want to make sure if someone states something, is that statement, is it enough of an assessment to properly do a proper intervention? Yes or no? And so you want to be aware of that. You also want to be aware of that as long as the patient can communicate, pain is always going to be subjective. So if the patient says it is, we cannot question them or kind of give them harass them about it. Just have to accept it. If they are unable to communicate, then it would be objective pain assessment scales, which are going to be scored by crying, moaning, groaning, guarding, vital signs, things like that. So when we're going through pain medications, it's important to remember that your non-opioid analgesics are NSAIDs with aspirin and then acetaminophen. Acetaminophen is not an NSAID. Okay, acetaminophen is not anti-inflammatory, where NSAIDs are. And that stands for non-steroidal anti-inflammatory drugs. So that's going to be your ibuprofen, your naproxen, ketorolac, and then also your aspirin and acetylsalicylic acid. Aspirin is kind of a special NSAID that has increased properties. So general NSAIDs, you're going to be aware of, it's going to inhibit your COX-1. COX-1 is good information that affects your GI tract. We generally do not want to inhibit that. So if we inhibit that, it's going to lead to increased risk of GI bleeding. So we want to ask our patients, do they have risk of GI, do they have a history of bleeding complications at baseline? Do they have a history of hepatic ulcer disease, GERD, or just GI bleeding? If so, we're going to want to make sure we assess for increased epigastric pain. Could be a sign of that GI bleed. Otherwise, it's going to inhibit COX-2, which is the bad inflammation. That's when we want to inhibit the inflammatory process that comes with tissue injury. We want to inhibit that. So other complications with NSAIDs is going to be a risk of kidney failure. So we want to assess your fluid status, BUN, creatinine, and make sure you are properly assessing and avoiding other medications that have kidney failure as well, or nephrotoxicity, whichever one I look at it. So in addition with aspirin, aspirin has all those other complications of NSAIDs, right? It's also antipyretic, but aspirin also has antiplatelet aggregation with it as well. So with that, there's even more increased risk of bleeding than with NSAIDs. It's systemic bleeding, thrombocytopenia, decreased platelets. You want to be aware of it. If you're doing anything for anticoagulation for a long term, you want to make sure you stop anticoagulation 7 days before surgery to help make sure there's no risk for bleeding in surgery. Other things with aspirin is you want to be aware of solipsism, which is the sign of aspirin overdose. First sign is going to be that tinnitus, ringing in the ears, hearing issues. From there, it's going to be like some CNS issues, depression, respiratory alkalosis initially because you're going to be breathing off a lot of the CO2 because you'll be acidotic, which will lead to just metabolic acidosis, respiratory depression, and just problems at baseline. Celecoxib has, or second generation NSAID, has less risk of GI bleed, but there's going to be an increased risk now due to vasoconstriction of having hypertensive events and then MIs and strokes due to the increased vasoconstriction, decreased blood flow to the tissue, increased risk of lack of perfusion in the organs. With NSAIDs, we also want to be aware that we are avoiding the 3 Gs for herbal remedies: garlic, ginger, and ginkgo. I'll make sure we're avoiding those. Next up is going to be acetaminophen. Acetaminophen, again, is not an NSAID. It does not have any anti-inflammatory properties. It is only analgesic and antipyretic. So whereas NSAIDs led to kidney failure, acetaminophen is going to now lead to liver failure. So we want to assess your ALT, AST, limit the dosaging up to 4 grams per ATI, 3 grams per textbook in evidence-based practice due to decreased risk of liver failure. The antidote for acetaminophen is going to be acetylcysteine. So if someone has an accidental or intentional overdose of acetaminophen, we're going to want to give oral acetylcysteine or potentially IV. It's going to bind to acetylcysteine in the system and make it inert. With opioids, we want to be aware of, this is all your common pain medications for severe to moderate pain: morphine, fentanyl, oxycodone, hydromorphone, all those. Schedule 2 medications. Schedule 2, remember, is going to mean that it has a risk for addiction, but there's also a medicinal value for it, so we can give it to patients. So with opioids, I want you to remember that there is a risk of CNS depression overall. With the CNS depression, you primarily want to look for is respiratory depression, respiratory rate less than 12. You also look out for bradycardia, hypotension, orthostatic hypotension. You want to look for just, the decreased LOC. You want to avoid giving them to patients with neurological trauma due to decreased LOC. You ask yourself, okay, what caused the mental status change? Was it the opioid or was it the neurological trauma? You also want to look out for constipation. When it comes to constipation, you want to give increased fluids and fiber to help make sure they don't have any sort of issues. And if that doesn't work, give laxatives. You want to assess for urinary retention. Make sure they're having at least 30 cc's of urine out per hour, or 0.5 to 1 mLs per kilogram per hour as well. You want to look out for any sort of allergic reaction for any medication, but with these primarily can lead to that itching, that histamine release. If they happen to give diphenhydramine, Benadryl to help prevent it. And then you also want to be aware of the risk for abuse. With that risk for abuse, remember, does that mean we cannot give them to patients who are previously addicted or have addicted personalities? So let's make sure we are hyper alert in giving to them and not give them long term. If there is a risk of overdose, we're going to give naloxone. Naloxone is going to be the opioid antagonist. So it's going to have a higher affinity for the receptors and block the opioid from causing the analgesia and then the CNS depression. The problem with this is we might also reverse too much of the opioid and then returning to the pain that we had before. So make sure we give just enough and not too much. We don't want to have the patient back in pain. Other anti-inflammatories. So glucocorticoids. Glucocorticoids there's not going to be any analgesic effect. It's primarily only going to be an anti-inflammatory. So what it does is it suppresses the bone marrow, suppresses white blood cells. With the bone marrow suppression, it's also going to suppress the red blood cells, so risk for anemia, lethargy, tired, weakness, decreased platelets, increased risk of systemic bleeding, increased risk of GI bleeding. Want to avoid other anticoagulants. Want to avoid NSAIDs, aspirin. You want to use soft bristle toothbrush, electric razor. Hold any bleed that's bleeding more than 10 minutes. Call the provider. Also caution the risk of GI bleed, peptic ulcer disease, and GERD. So you have increased of GI bleed with the decreased platelets and just bleeding in general. You also want to be aware of decreased white blood cell count, which again is going to lead to increased risk of infection, which is going to be the telltale sign of a fever. So temperature greater than 100.5 or up, you're going to want to just call the provider and make sure they get that checked out. Hyperglycemia, increased blood sugars. You want to avoid patients with diabetes mellitus. Hypernatremia. Hypernatremia is going to then lead to hypokalemia. So you want to assess sodium levels less than 135 to 145, potassium 3.5 to 5. With the hypernatremia, you also want to assess risk for edema, hypertension, fluid volume overload, and basically risks of angina, MI, cardiac complications. You also have osteoporosis. Osteoporosis and bone marrow suppression are not the same thing. They are separate, so you want to be aware of that. So with osteoporosis, you want to give your vitamin D and calcium. Vitamin D helps absorb calcium. And then you also want to do lightweight breathing exercises to help increase the bone strength. Long-term use of glucocorticoids can do Cushing's, which is going to be a lot of weight gain, fluid volume overload, the moon face, buffalo hump, things like that. We do not also want to stop glucocorticoids quickly. We want to taper down the dose, because if we stop too quickly, it can lead to an increase in your cortisol and then also can lead to Cushing's. When it comes to migraine medications, there's a lot of medications you can use, but there's going to be certain concepts that will match throughout. So you want to assess for new triggers, assess the triggers. You want to abort the migraine before it sets in. So when the aura starts, that's when we're going to want to give the medication. You want to avoid the triggers, and if the migraines are becoming more persistent, we're going to want to look for new triggers. We can either add a new medication, or we can swap the medication altogether to a brand new one. There's two main migraine medications we talk about. It's going to be the triptans, so sumatriptan, and ergot alkaloids, ergotamine. The triptans end in triptan. The ergot alkaloids start with ergot, so easy way to identify them. Either way, they both are going to work through vasoconstriction. If you're constricting the blood vessels, you are going to be at risk of hypertension. You are now at risk of angina, chest pain, cardiac complications. You're also decreasing blood flow. So you're going to have decreased cerebral perfusion. And with decreased cerebral perfusion, you're also going to have a risk of loss of LOC. So you kind of want to make sure you are assessing the LOC on top of the blood pressure, and that's actually the pain itself. So with these, we're also going to want to make sure we avoid any other CNS stimulant. Any other CNS stimulant is going to increase the risk of seizure activity, increase the risk of hypertension, cardiac problems. So we want to make sure we avoid those at all costs. And that has been a review of pain medications. If you have any questions, let me know.